Your doctor is not lying to you, but the protocol they follow was designed for a 45-year-old body, not yours. And that difference between the standard diabetes management guideline and what the research actually says about bodies over 55 is the reason you check your numbers every morning and they still won't move. I'm Dr. Michael Reed, internal medicine physician and metabolic health specialist. I spent the first 12 years of my career following the standard protocol, adjusting doses, repeating the same advice, watching my patients do everything right, and still get worse year after year. A1C creeping up, fasting glucose that wouldn't budge, medication list growing. I didn't leave that system because I'm a rebel. I left because the science told me to. Because the research on insulin resistance, liver glucose production, and muscle metabolism in adults over 55 had moved far beyond the standard of care playbook, and nobody was translating it for the people who needed it most. So that's what we do on this channel. Not conspiracy theories, not miracle cures. Peer-reviewed clinical science, translated into something you can actually use. Today's video is about something very specific and very uncomfortable, the way standard diabetes management is, in certain measurable ways, making your condition harder to control as you age. Not because of negligence, because of a system designed around populations, not individuals, around averages, not the specific biology of someone who is 62 years old, has had type 2 diabetes for 8 years, and is doing everything their doctor said to do. We're going to cover 5 mechanisms actively working against your blood sugar control right now, mechanisms your current medication may not be touching. Then I'm going to give you the protocol I walk every new patient through, specific, evidence-based, designed for a body over 55. By the end of this video, you're not going to feel confused about your diabetes anymore. You're going to feel angry at how long this information was kept from you, and then you're going to feel ready to do something about it. If this channel is new to you, I ask one thing: hit subscribe, not for me. Because there are tens of millions of seniors with type 2 diabetes who have been told their condition is progressive and irreversible. The clinical evidence says otherwise. They need to hear that. The algorithm decides how many of them see this video based on how many of you subscribe. That's the system. Let's use it. Let's start with the problem nobody's explaining to you. The standard diabetes guideline was built primarily on data from middle-aged adults. When the clinical trials that established HbA1c targets, medication thresholds, and dietary recommendations were designed, the majority of participants were in their 40s and early 50s. The biology of a 65-year-old diabetic body is not a scaled-up version of that. It's a fundamentally different metabolic landscape, and the clinical evidence says so directly. Study 1. The DIRECT trial. Published in The Lancet in 2018 with 5-year follow-up data published in 2024. A cluster randomized controlled trial. 306 adults with type 2 diabetes, average age 52, diagnosed within the past 6 years. One group received standard diabetes care. Doctors adjusted medication, gave dietary advice, the usual protocol. The other group followed a structured dietary intervention, and critically, their diabetes medications were withdrawn from the start. What happened? At 1 year, 46% of the intervention group achieved complete remission, defined as HbA1c below 6.5% without any medication. The control group, the ones on standard care, 4% in remission. At 5 years, 27% of the original intervention group were still in remission, still off medication, 5 years later. The research team, led by Professor Mike Lean at the University of Glasgow and Professor Roy Taylor at Newcastle University, concluded that the progression of type 2 diabetes is not inevitable. That is not my opinion. That is The Lancet. When was the last time your doctor mentioned the word remission? And here's what that study also revealed. The part most people miss. It wasn't the total weight loss that drove remission. It was the reduction of fat specifically from the liver and the pancreas. Patients who lost more than 10 kilograms had a 64% remission rate. Patients who lost more than 15 kilograms, 86% remission rate. That's not a pharmaceutical effect. That's not surgery. That's the removal of fat from 2 specific organs. And I'm going to explain exactly why those 2 organs are at the center of your blood sugar problem in just a moment. Study 2. Researchers at George Washington University published a study in Diabetes Care, one of the 2 most prestigious diabetes journals in the world, specifically designed for adults over 60. Dr. Loretta DiPietro and her team took seniors age 60 and above with prediabetes and compared 2 exercise protocols. Group 1, 45 minutes of continuous walking once a day. Group 2, 3 short walks of 15 minutes each, one after each main meal. The result wasn't close. The 3 short post-meal walks produced significantly better 24-hour blood glucose control than the single 45-minute walk. Not slightly better, significantly better, measured using a 24-hour whole-room calorimeter. Gold standard methodology. This study was designed specifically for seniors over 60, and it showed that the optimal intervention for this population, 3 short walks, is something virtually any senior can do, regardless of fitness level or joint limitations. Study 3, published in Diabetes Care in 2025 from Weill Cornell Medicine. Dr. Candida Rebello and her team ran a randomized crossover trial with 20 adults, average age 59 years, with type 2 diabetes on metformin. They tested one specific change, the order in which food was eaten during a meal. Same calories, same foods, different sequence. When participants ate carbohydrates last, after vegetables and protein, their peak blood glucose spike was reduced by 44%, without changing any medication, without changing the total amount of food eaten, without eliminating a single food. That study replicated and extended an earlier Weill Cornell paper, Shukla and colleagues, 2015, which showed the same carbohydrate last sequence reduced the post-meal glucose area under the curve by 73% in type 2 diabetics, 73% reduction in post-meal glucose impact, from changing the order you eat, not the amount, the order. That's not alternative medicine, that's Weill Cornell, that's diabetes care, that's peer-reviewed science. The problem isn't that this evidence doesn't exist. The problem is that a 10-minute appointment with your primary care doctor doesn't allow for the translation of this research into your daily life, so it never reaches you. That's the gap this channel exists to close. There isn't one reason your blood sugar is stuck. There are 5 interconnected mechanisms. When you understand all of them, the protocol becomes obvious, and when you understand why they are especially aggressive after the age of 55, the urgency becomes clear. Let me take you through each one. Your skeletal muscle is the largest glucose disposal system in your body. Under normal conditions, with insulin working properly, muscle tissue is responsible for absorbing approximately 80% of the glucose in your bloodstream after a meal. Think of it as a biological sponge, a big one, soaking up the excess glucose before it has a chance to cause damage. Here's what happens to that sponge as you age. Starting in your 30s, you begin losing skeletal muscle mass at a rate of roughly 0.5 to 1% per year. That process, called sarcopenia, accelerates significantly after 60. By the time a person reaches 75, they may have lost 30 to 50% of their peak muscle mass. Now add type 2 diabetes to that picture. Chronic high blood glucose damages muscle tissue through a process involving advanced glycation end products, AGEs, and produces systemic inflammation that further breaks down muscle protein. The diabetes accelerates the sarcopenia. The sarcopenia worsens the diabetes. It's a closed loop that gets tighter every year. The critical molecule here is called GLUT4, a glucose transporter protein that lives predominantly in skeletal muscle. When insulin binds to a muscle cell, GLUT4 moves from inside the cell to the surface and opens a channel for glucose to enter. Less muscle means fewer GLUT4 transporters. Fewer transporters means glucose stays in the bloodstream longer after every meal. A 2023 analysis confirmed sarcopenia is independently associated with elevated HbA1c in adults over 60 with type 2 diabetes. But here's what the research also shows, and this is where it gets genuinely empowering. That GLUT4 transporter has 2 activation pathways, the insulin pathway, which doesn't work well in type 2 diabetes, and a completely independent pathway triggered by muscle contraction. When muscle fibers contract during a gentle walk, GLUT4 moves to the cell surface regardless of whether insulin is present or functioning properly. You can bypass the broken pathway. The emergency door is still wide open. Emergency door is what this entire protocol is built around. Raise your hand if your fasting glucose in the morning is higher than your doctor wants, even though you ate well the night before. You haven't eaten in 8 hours. Where is that glucose coming from? Your liver. Every night while you sleep, your liver runs a night shift. It releases stored glucose into your bloodstream, gluconeogenesis and glycogenolysis, to keep your brain fueled during the fast. In a person without diabetes, the pancreas detects this output and releases a small, precise pulse of insulin that brings levels back in range. In type 2 diabetes, particularly after age 55, that regulatory pulse is blunted or absent. The liver keeps releasing glucose, and between approximately 3 a.m. and 8 a.m., when cortisol peaks, when growth hormone surges, when adrenaline begins to rise in preparation for waking, the liver receives direct stimulation to release even more. This phenomenon has a name, the dawn phenomenon, and it is responsible for the high fasting glucose that puzzles and frustrates so many of my patients. Monnier and colleagues published the clinical evidence in diabetes care in 2012. They studied 81 diabetic patients across 3 age groups. The dawn phenomenon was present in 52 to 70% of seniors, and more importantly, it adds an average of 0.39% to HbA1c, independently of everything else the patient is doing: their medication, their diet, their exercise. Think about what that means in practice. If your A1C is 7.6% and your target is 7.0%, the dawn phenomenon alone may be responsible for 0.3 to 0.4 of those percentage points. Not your diet, not your compliance, your liver's night shift. When did your doctor last explain that your morning fasting glucose may have nothing to do with what you ate? You've heard the term insulin resistance. Most doctors explain it this way: your cells don't respond to insulin properly. That's accurate, but it's incomplete, and the incomplete version leads to the incomplete intervention. Insulin works like a key. Your cells have locks, called insulin receptors, on their surface. When insulin binds to the receptor, it triggers a cascade of signals that ultimately moves GLUT4 to the surface. In insulin resistance, the key still fits, but the lock is rusted. The binding happens. The cascade starts, but downstream, the chain breaks. The GLUT4 doesn't move to the surface efficiently. Glucose stays in the bloodstream. The pancreas produces more insulin. But the locks are still rusted. More keys, same rusted locks. Higher insulin, same resistance. What rusts the lock? 2 things primarily. First, visceral fat, fat stored around internal organs, produces large quantities of inflammatory molecules IL-6 and TNF-alpha, which physically interfere with the insulin receptor signaling pathway. More visceral fat, more inflammation, more rusted locks. Second, fat droplets that accumulate inside muscle cells themselves, intramyocellular lipid, directly impair the cell's insulin response. Why does this worsen after 55? Because visceral fat accumulation increases with age. Because the inflammatory state called inflammaging, the chronic low-grade inflammation associated with normal aging, amplifies the effect of these inflammatory molecules. And because the mitochondria inside muscle cells become less efficient, accelerating intramyocellular fat accumulation. Your pancreas contains clusters of cells called beta cells. Their one job: detect rising blood glucose and release insulin in 2 phases, a rapid burst within 2 minutes of eating, then a sustained release for the following 2 hours. In type 2 diabetes, both phases are blunted. But the mechanism isn't a genetic defect in most patients. It's a hostile environment. Intrapancreatic fat, fat deposited specifically inside pancreatic tissue, directly impairs beta cell function. This is the twin cycle hypothesis from Professor Roy Taylor at Newcastle, and the direct trial demonstrated it clinically. When intrapancreatic fat is reduced through significant weight loss, beta cell function recovers measurably, even in patients who have had diabetes for years. The implication is profound. The question is not whether your beta cells can recover. The question is whether your intervention is specifically designed to reduce fat from the liver and the pancreas. Standard dietary advice doesn't address this directly. Metformin doesn't address this directly. The protocol I'm about to give you does. The dawn phenomenon peaks between 6 and 8 a.m. Cortisol is at its daily high. The liver has been producing glucose for hours. Your fasting blood sugar is already elevated. Now consider the standard healthy breakfast most seniors with diabetes eat. Instant oatmeal, glycemic index 83. Whole wheat toast, glycemic index 70. Orange juice, 26 grams of sugar, 0 fiber. You're loading fast carbohydrates into a system already flooded with glucose from the dawn phenomenon, at the moment when your insulin response is most compromised. Then something counterintuitive happens. The post-breakfast spike triggers a large insulin release. blood glucose eventually drops. But in many seniors on sulfonylureas or with dysregulated response, it overcorrects. By 10 or 11 a.m., fatigue, fogginess, sudden hunger. You reach for a snack, probably a carbohydrate. The cycle restarts. This is not a willpower problem. This is a biology problem. Breakfast for a person with type 2 diabetes over 55 is the most metabolically dangerous meal of the day. Not because food is the enemy, because timing and context are everything. The fix is not complicated, but it is not what your doctor told you. This is where the protocol begins. Enough background. Here is the protocol. No theory, just what works and why. Priority 1, the food sequence. At every meal, every single one, eat your food in this order. First, non-starchy vegetables, salad, broccoli, cauliflower, spinach, asparagus, zucchini, cucumber, green beans. Eat these first, not as a side dish after the fact. First. Second, protein, chicken, fish, eggs, Greek yogurt, cottage cheese, tofu, legumes. Eat this second. Third, carbohydrates, bread, rice, pasta, potato, corn, fruit. Eat these last. Every time. Same plate, same calories, same foods, just different order. Why does this produce a 44% reduction in peak blood glucose? The fiber in the vegetables slows gastric emptying. It physically delays the rate at which food leaves your stomach. The protein stimulates the release of GLP-1, a hormone that further slows digestion and primes the pancreas for the glucose wave coming from the carbohydrates. By the time the carbohydrates reach your small intestine, the velocity of glucose absorption has been dramatically reduced. The spike flattens. No special equipment, no meal prep, at any restaurant, at any dinner table with any meal you already eat. Simply eat the vegetables first, then the protein, then the starch. You don't need to wait between each food. Just prioritize the order. The common mistake: eating everything simultaneously without thinking about sequence. That one habit eliminates most of the benefit. Sequence. Every meal. Every time. Priority. 2. The post-meal walk. Within 20 minutes of finishing each main meal, walk for 10 to 15 minutes. After breakfast, after lunch, after dinner. The mechanism: the peak blood glucose. After a meal occurs between 30 and 60 minutes after eating. A walk started within 20 minutes of finishing catches this peak. Muscle contraction activates GLUT4 through the insulin-independent pathway, the emergency door we covered. The skeletal muscle becomes a passive glucose drain at exactly the moment when blood glucose is highest. The DiPietro study showed 3 15-minute post-meal walks in seniors over 60 outperformed 45 minutes of continuous walking for blood glucose control. A 2025 study in Scientific Reports found even a 10-minute walk immediately after a meal reduced the glucose peak by 17% compared to sitting. You don't need fitness shoes. You don't need a specific pace. You need muscle contraction during the post-meal glucose window. For limited mobility, even standing with support, seated leg raises, or gentle chair exercises activates enough muscle contraction to engage the GLUT4 mechanism. The movement matters. The form does not. If you take insulin, monitor your glucose before the walk and approximately 90 minutes after. Post-meal exercise with active insulin on board can lower blood glucose more than expected. Know your individual pattern before establishing a routine. Priority. 3. The breakfast restructure. Given the dawn phenomenon, cortisol at its daily peak, liver producing glucose since 3 a.m., insulin response at its most blunted, breakfast requires a specific reconfiguration. The goal: protein and fat as the primary macronutrients for the first meal of the day. Instead of instant oatmeal, Greek yogurt with berries and a tablespoon of ground flaxseed. 15 to 20 grams of protein, minimal glucose impact. Instead of whole wheat toast, 2 eggs with spinach and half an avocado. High protein, healthy fat, near zero glucose impact. Instead of orange juice, water with a tablespoon of apple cider vinegar diluted in 200 milliliters. I'll explain the vinegar in a moment. If you want oatmeal, use steel-cut oats, cooked the night before and eaten cold or lightly reheated. The cooling process converts a portion of the starch to resistant starch, reducing the glycemic index from approximately 79 to approximately 54. Target: 25 to 30 grams of protein at breakfast, not 10 grams, not a light meal. A protein-anchored first meal that blunts the cortisol-driven glucose environment of the morning. The most common breakfast mistake I see, patients switch from white bread to whole grain bread. Glycemic index moves from 73 to 69. That is not a solution. The structural problem, loading fast carbohydrates into a cortisol-elevated metabolic environment at 7 a.m., remains unchanged. Now, supplements. I want to be precise about what the evidence supports, at what dosages, and critically, what interactions exist with common diabetes medications, because this is where misinformation is most dangerous. Berberine, 500 milligrams 2 to 3 times per day with meals. Berberine activates an enzyme called AMPK, adenosine monophosphate activated protein kinase, the master metabolic regulator in human cells. When AMPK is activated, the liver reduces glucose production, muscle cells increase glucose uptake, insulin sensitivity recovers. Metformin, the most commonly prescribed diabetes medication in the world, also activates AMPK. This is not coincidental. This is why berberine and metformin produce overlapping effects. A 2023 meta-analysis analyzing 46 randomized controlled trials with over 2,000 patients found that berberine produced statistically significant reductions in fasting glucose, post-meal glucose, and HbA1c, with effect sizes comparable to first-line oral diabetes medications. One landmark Chinese trial documented HbA1c reduction from 9.5% to 7.5% with berberine monotherapy over 3 months. Critical safety note, and I'm going to be direct here. If you take metformin, do not start berberine without discussing it with your prescribing physician first. Both activate AMPK. The combination may produce a larger glucose-lowering effect than either alone, which requires awareness and monitoring. If you take insulin or sulfonylureas, this precaution is even more important. Berberine is not a harmless supplement. It is a metabolically active compound with drug-level effects. Treat it accordingly. Magnesium glycinate, 300 to 400 milligrams nightly. Studies consistently show that 30 to 40% of adults with type 2 diabetes are deficient in magnesium, a cofactor for over 300 enzymatic reactions, including those involved in insulin receptor signaling. A 2021 meta-analysis found that magnesium supplementation in deficient diabetic patients reduced fasting blood glucose by 0.56 mmol and HbA1c by 0.38%. Use the glycinate form, highest bioavailability, lowest rate of GI side effects. If your kidney function is impaired, eGFR below 30, consult your physician before supplementing. Apple cider vinegar, 15 to 20 milliliters in 200 milliliters of water before the highest carbohydrate meal of the day. Acetic acid, the active component, inhibits the digestive enzymes that break down starch into glucose. The effect is similar in mechanism to acarbose, a pharmaceutical glucose-lowering agent. Multiple randomized controlled studies document 20 to 34% reduction in post-meal blood glucose. Timing is critical, before the meal, not after. Always diluted. Undiluted vinegar causes esophageal and enamel damage. Do not use if you have gastroparesis or a history of peptic ulcer disease without clearance. Now, foods. Foods that actively support glucose control in seniors with type 2 diabetes. Legumes, lentils, chickpeas, black beans, 100 grams cooked per serving, the lowest glycemic response of any carbohydrate food. They also improve blood glucose at the meal that follows, the documented second meal effect. Non-starchy vegetables, minimum 2 cups per meal. The sequencing mechanism works through fiber content. More fiber, stronger effect. Fatty fish, salmon, sardines, mackerel, 2 to 3 times per week. Omega-3 fatty acids reduce visceral fat accumulation over time and have anti-inflammatory effects relevant to the insulin resistance mechanism. Eggs, 2 to 3 per day. The dietary cholesterol concern has been substantially revised in recent literature. The protein and fat combination produces minimal insulin response. Ground flaxseed, 1 to 2 tablespoons daily. The mucilage fiber is among the most effective dietary interventions for slowing glucose absorption. Foods that spike blood glucose more than they appear to. Fruit juice, including fresh orange juice. Without the fiber of whole fruit, the glucose reaches the bloodstream at the same velocity as a soft drink. 1 cup contains 26 grams of sugar and essentially 0 fiber. Instant oatmeal, Glycemic index 83. The processing destroys the structural integrity of the beta-glucan fiber that gives oatmeal its glucose-controlling properties. Switch to steel cut. Whole wheat bread. Glycemic index 68 to 72 compared to white bread at 70 to 75. The health halo is largely unwarranted from a glucose perspective. Low-fat flavored yogurt often contains 20 to 30 grams of added sugar per serving to compensate for the loss of fat's contribution to flavor. Full-fat plain Greek yogurt is the superior metabolic choice. Before you implement any part of this protocol, I need to cover safety directly. If you take metformin, the dietary changes I've described can meaningfully lower your blood glucose. Metformin's glucose-lowering effect remains constant. In the first 2 to 4 weeks, monitor your fasting glucose daily. If you see consistent readings below 80 mg/dL in the morning, contact your physician to discuss whether a dose adjustment is appropriate. This is a success problem, not a failure, but it requires medical oversight. If you take insulin, do not implement significant carbohydrate reduction without your physician's or endocrinologist's explicit guidance. A meaningful reduction in dietary carbohydrates requires a calibrated reduction in insulin dosing. Without adjustment, the combination can produce hypoglycemia. Coordinate your changes with your prescriber before beginning. If you take sulfonylureas, glipizide, glibenclamide, gliclazide, these drugs stimulate insulin secretion independent of your blood glucose level. Combined with aggressive carbohydrate reduction, hypoglycemia risk is real. Know the symptoms of hypoglycemia: trembling, cold sweat, palpitations, sudden hunger, dizziness, confusion, difficulty concentrating. If any of these occur, eat 15 grams of fast-acting carbohydrate immediately. Glucose tablets, 150 milliliters of fruit juice, 3 or 4 hard candies. Recheck glucose in 15 minutes. If below 70 mg/dL with persistent symptoms, seek medical attention. Based on the clinical evidence, here is what to realistically expect. Week 1 to 2. You'll notice changes in how you feel before you see them in your numbers. The afternoon energy crash, the 3 p.m. fog many seniors with diabetes experience, tends to improve within the first week of food sequencing and post-meal walking. Your post-meal glucose readings should show measurable improvement. Month 1. Fasting glucose typically drops 5 to 15 points with consistent implementation of the breakfast restructure and the post-meal walk. This is also when patients notice improved energy and reduced mid-morning hunger, the cortisol-glucose cycle starting to break. Months 2 to 3, HbA1c begins to reflect the cumulative change. HbA1c represents the previous 8 to 12 weeks of average blood glucose. The first significant improvement appears between weeks 6 and 12. Studies show HbA1c reductions of 0.3 to 0.8 percentage points in this window. In patients who achieve meaningful weight loss of 5 to 10 kilograms, reductions are greater. Months 3 to 6, bring your glucose log to your physician. If numbers have improved consistently, the conversation about medication adjustment becomes appropriate. Ask the question. Bring the data. Let me close with the most important thing I can say in this entire video. For 40 years, the conventional medical position on type 2 diabetes was this: it is progressive. Once you have it, the best you can do is manage it. Slow the progression, never reverse it. That position was not based on evidence of what is biologically possible. It was based on the results of an approach, standard pharmaceutical management combined with standard dietary advice, that was never designed to address the root mechanisms of the disease. In 2018, the DIRECT trial, published in The Lancet, the most prestigious medical journal in the world, showed that 46% of adults with type 2 diabetes achieved complete remission through dietary intervention alone, defined as HbA1c below 6.5% off all diabetes medications sustained for 12 months. No surgery, no experimental drug, food and timing. Your doctor may not have told you that trial exists. Now you know, and now you have the protocol. Your metabolism is not broken. It has been given the wrong instructions. And after 25 years of watching patients follow those wrong instructions and get progressively worse, and then watching patients follow the right ones and reverse course, I can tell you with the certainty that comes from a quarter century of clinical practice, the right instructions exist. They are evidence-based, they are accessible, and you now have them. Let's recap what we covered today. 1. The shrinking sponge. The muscle you've lost since 55 is the same muscle that absorbed 80% of your blood glucose. Post-meal walking rebuilds a glucose disposal pathway that no medication replaces. 2. The liver's night shift. Your fasting glucose in the morning is often a liver problem, not a diet problem. The dawn phenomenon adds up to 0.4 points to your HbA1c independently. Restructuring breakfast is the primary intervention. 3. The rusted lock. Visceral fat is physically blocking your insulin receptors through chronic inflammation. The protocol directly targets visceral fat reduction, not just overall weight. 4. The pancreas under siege. Reducing liver and pancreatic fat is the specific mechanism behind beta cell recovery. The direct trial proved it clinically. The progression is not inevitable. 5. The breakfast betrayal. The dawn phenomenon makes 7 a.m. the worst moment of the day to eat fast carbohydrates. Protein anchor your mornings and the entire day's glucose profile shifts with it. And tell me in the comments, what is the one thing about your diabetes your doctor has never taken the time to explain to you? I read every single comment, every one, because those questions tell me exactly what the next video needs to cover. If someone you know is living with type 2 diabetes or has been told they're pre-diabetic and brushed it off, share this video. Not for the views, for the possibility that they find out their biology is not a life sentence before complications develop. Next week, the specific hormonal mechanism behind what happens to your blood glucose during the first 6 hours of sleep, and why getting that window right can move your fasting numbers more than any supplement on this list. You do not want to miss it. This is Dr. Michael Reed. Know your numbers, own your health.